If you're over 65 and your doctor told you that 120/80ths is the perfect blood pressure, what I'm about to share may genuinely surprise you. Not because 120/80ths is wrong, not because your doctor made a mistake, but because the story of blood pressure after 65 is significantly more complicated than that single number suggests. And the part of the story most seniors never hear, the part that's been sitting quietly in the research for years, is the part I want to spend time on today. Because there is something happening in doctors' offices across this country every single day that nobody is talking about clearly. Seniors are having their blood pressure pushed lower and lower in pursuit of a number that was originally studied in younger adults. And for some of them, not all, but a meaningful number, that pursuit is making them feel worse, fall more, think less clearly, and age faster than they need to. I've sat with these patients. I've listened to what they describe. And I want you to hear it too, because it might sound familiar. Let me tell you about a woman I'll call Norma. 78 years old. Sharp woman. Former accountant. She came into my office looking more tired than I'd seen her in years. Her daughter was with her, and before Norma could say anything, her daughter said, "She keeps getting dizzy when she stands up. She nearly fell twice last week." Norma's blood pressure at her last several appointments had been sitting around 118/68. Her previous doctor had considered that excellent. Nearly perfect, she'd been told. She was on 3 blood pressure medications to achieve it. But here's what nobody had connected. Every time Norma stood up from a chair, from the dinner table, from the couch, from the toilet, her blood pressure dropped sharply. The world tilted. She grabbed for something. Twice, she almost didn't grab in time. She wasn't dizzy because something was wrong with her ears or her inner balance or her brain. She was dizzy because her blood pressure was being held so low that her aging cardiovascular system could not quickly enough compensate for the change from sitting to standing. The blood pooled in her legs for a few seconds before the system caught up. And in those seconds, her brain was receiving less blood than it needed. We adjusted her medications. Her blood pressure settled around 134/76. Her dizziness resolved within 2 weeks. She called to tell me she felt like herself again, that she'd been feeling vaguely unwell for almost a year and hadn't realized how much until it stopped. That number, 118, had been doing her harm while everyone called it perfect. Here's the thing most people don't know about where the 120/80ths standard came from. The target was established based largely on research done in middle-aged adults. People in their 40s and 50s whose arteries, hearts, and nervous systems were responding to blood pressure treatment in specific, predictable ways. The evidence from that population showed clearly that keeping systolic pressure, that's the top number, around 120 reduced cardiovascular events significantly. And that evidence is real. It's solid. For the population it was studied in. But the body at 70 is not the body at 50. And this is where things get medically interesting and practically important. Think of your arteries in your 60s and 70s like a garden hose that's been in the sun for years. When a hose is new and flexible, it expands and contracts easily with changes in water pressure. Squeeze the flow, the hose adjusts. Release it, the hose adjusts back. Smooth, responsive, automatic. An older hose, one that's become stiff and slightly rigid, doesn't adjust as easily. Change the pressure and the hose takes time to compensate. It doesn't stretch and recoil the way it once did. That stiffening is what happens to arterial walls over time. It's called arterial stiffness, and it changes everything about how blood pressure should be interpreted and managed after 65. Because in a stiffer arterial system, the relationship between the top number and the bottom number changes. And pushing the entire system lower in pursuit of a target designed for more flexible arteries can create problems that weren't there before. Most people never hear this explanation. Most people just hear, lower is better. Get to 120. Stay there. But lower is not always better. And the research on this, emerging clearly over the past decade, is something every senior managing blood pressure deserves to understand. Let me explain the two numbers, because the distinction matters more after 65 than most people realize. The top number, systolic pressure, measures the pressure in your arteries when the heart beats and pushes blood out. The bottom number, diastolic pressure, measures the pressure when the heart rests between beats. In younger adults, both numbers tend to move together. When blood pressure rises, both go up. When treatment brings it down, both come down proportionally. In older adults with arterial stiffness, this changes. The systolic number often rises steeply. The stiff arteries don't absorb the force of each heartbeat as well, so the pressure spikes higher with every pump. But the diastolic number may stay the same, or even fall, because the arteries don't recoil and maintain pressure as efficiently between beats. This creates a widening gap between the two numbers. A systolic of 155 with a diastolic of 68 is a very different situation physiologically than a 35-year-old with 128/80ths. And treating the older person aggressively to bring that top number down to 120, if it also pulls the bottom number below 60, can be genuinely dangerous. Here's why the diastolic number matters so much. The heart itself, the coronary arteries that feed the heart muscle, fills with blood during the diastolic phase, between beats. When the diastolic pressure falls too low, the heart muscle may not receive adequate blood flow during that rest phase. This is called diastolic hypoperfusion, and it's one of the mechanisms through which aggressive blood pressure lowering in older adults can paradoxically increase the risk of heart attack rather than reduce it. Pay attention to this. If your diastolic pressure, the bottom number, is consistently below 65 or 70 and you're over 65, that is a specific finding worth discussing with your doctor. Not because it's automatically dangerous, but because it's a data point that changes the risk calculation. The next finding surprised researchers when it was clearly documented. And it has a name, the J-curve phenomenon. For decades, the assumption in cardiology was linear. Lower blood pressure equals lower cardiovascular risk. Always. The relationship runs one direction only. Down is better, indefinitely. But when large studies began following older adults who had their blood pressure treated very aggressively, a curve appeared in the data. Risk decreased as blood pressure came down from high levels, yes. But at a certain point, when systolic pressure fell below around 120, and particularly when diastolic pressure fell below around 65 to 70, the risk curve bent back upward. Risk began to increase again at the very low end, a J shape, not a straight line. This doesn't mean blood pressure treatment is wrong or that high blood pressure is safe. High blood pressure remains one of the most significant cardiovascular risk factors that exists. The J-curve finding doesn't change that. What it means is that there is a floor, and in older adults, that floor may be higher than it is in younger people. That the aggressive pursuit of the lowest possible number, past a certain point, may stop being protective and start being harmful. This is where many seniors get into trouble. Not because their doctor is careless, but because the target was set without fully accounting for the physiology of an older arterial system. Let me introduce you to someone else. Harold, 73, former high school principal. He'd been managing his blood pressure for 15 years and had always been conscientious about it. When a new guideline came out recommending more aggressive treatment, his doctor, following the updated recommendations appropriately, added a second medication to bring his systolic pressure from 138 down toward 120. Harold's blood pressure reached 119/61 within 6 weeks. And Harold started having trouble at work meetings. He'd lose his train of thought mid-sentence. He'd read something and immediately not be able to recall it. He assumed it was early dementia. His wife assumed it. He told me later that the fear of what was happening to his mind was, looking back, the worst part of that entire year. It wasn't dementia. It was his brain not receiving adequate blood flow during the hours he was sitting at a desk, concentrating, demanding peak cognitive performance from a brain that was being chronically underperfused. The brain is enormously sensitive to blood pressure changes. It requires consistent, adequate pressure to maintain cerebral perfusion, particularly in older adults whose cerebral autoregulation, the brain's ability to manage its own blood flow, becomes less efficient with age. When systolic pressure drops significantly below where an older brain has been operating, cognitive symptoms can appear that look exactly like the early stages of neurological decline. When Harold's diastolic pressure fell below 60, his brain was working hard just to keep up with basic function. Focused concentration, the kind a meeting demands, was beyond what it could reliably deliver at that pressure. We reduced one medication. His blood pressure settled at 132/74. His cognitive symptoms resolved within a month. His neurologist, who had evaluated him during that period, told him afterward, "You didn't have early dementia. You had undertreated low blood pressure." I think about Harold often when I see a senior with newly appeared cognitive complaints and a blood pressure that's been recently tightened. Now let me talk about something that Norma's story touched on, but deserves its own full explanation. Orthostatic hypotension. It sounds technical. The concept is simple. When you stand up from sitting or lying down, gravity immediately pulls blood toward your lower body, your legs, your abdomen. Your cardiovascular system has to respond very quickly, constricting blood vessels, slightly increasing heart rate, to maintain blood pressure to the brain during that transition. In a younger person with responsive arteries and a nimble nervous system, this compensation happens in 1 to 2 seconds. Imperceptible. In an older person, particularly one whose arteries are stiff, whose autonomic nervous system is less reactive, and whose blood pressure is being held lower by medication, that compensation is slower. Blood pressure drops for 3, 4, 5 seconds after standing. The brain gets less blood during that window. The result is lightheadedness on standing, brief vision changes, the need to grab something, a feeling that the room tilted for a moment. In mild cases, it's uncomfortable and disorienting. In more significant cases, in a person who is already at risk for falls, it is one of the primary mechanisms through which blood pressure medication contributes to falls, fractures, and the cascade of consequences that can follow. Here's the test you can do at home, and I want you to actually do this. Lie down for 5 minutes. Then take your blood pressure. Write it down. Stand up immediately. Take your blood pressure again within 1 to 2 minutes of standing. Write that down too. If the top number drops by 20 or more points, or the bottom number drops by 10 or more points when you stand, that is orthostatic hypotension. That is a finding your doctor needs to know about. By name. With your measurements. Most people who have this have never been tested for it, because it doesn't show up in a blood pressure reading taken while you're sitting still in an exam room, which is the only reading most doctors take. There's a third patient I want to tell you about, because his story is the one that stays with me most. Leonard, 81 years old. Veteran. Stoic man who didn't like to complain. His daughter brought him in after he fell in the bathroom at night. He wasn't injured badly, some bruising, a small cut on his arm. But his daughter was frightened. Leonard told me he'd been getting up at night to use the bathroom and feeling unsteady, He'd thought it was just age. He hadn't wanted to say anything. His blood pressure on standing, measured specifically, something that had never been done in his chart, dropped 42 points within 90 seconds of him rising from the exam table. He was on 4 blood pressure medications. His seated pressure was 116/64. His cardiologist had been pleased with the numbers. Standing, his systolic dropped to 74. His brain, in those moments in the dark hallway walking to the bathroom, was receiving the blood pressure of someone in cardiovascular compromise. He wasn't falling because he was old. He was falling because his brain was temporarily starved of blood every time he stood up. We reduced his medications carefully, working closely with his cardiologist. His standing blood pressure stabilized. His nighttime falls stopped. He came back 6 months later and shook my hand and didn't say much. Leonard wasn't a talker, but his daughter said he hadn't fallen once since the medication change, and that he'd started going for a walk in the mornings again. That walk, that return of confidence in his own legs, that is what blood pressure management is supposed to protect, not a number on a chart. So what do I want you to do with all of this? First, I want to be absolutely clear. Do not stop or reduce any blood pressure medication on your own. Please. The risks of unmanaged high blood pressure, stroke, heart attack, kidney damage are real and serious. What I'm describing is not a reason to abandon treatment. It is a reason to have a more specific, more informed conversation with whoever manages your care. Second, start measuring your blood pressure at home. Consistently. At the same times each day. Morning before medication and before coffee. Evening before bed. Write the numbers down. Date, time, reading. 2 weeks of this data is more valuable to your doctor than a dozen single readings taken in an office. Third, do the standing test I described. Lie down for 5 minutes. Take your blood pressure. Stand up. Take it again. If there's a significant drop, tell your doctor, specifically with numbers, that you may have orthostatic hypotension and you'd like it properly evaluated. Fourth, look at your diastolic number. If the bottom number is consistently below 65 or 70, not occasionally, but most of the time, bring that to your doctor's attention specifically. Ask, is this diastolic reading too low for my age? That question, asked directly, may open a conversation that hasn't happened yet. Fifth, ask your doctor this specific question. Given my age, my overall health, and all of my risk factors, what is the right blood pressure target for me specifically? Not for a general guideline, but for me. A good physician will engage with that question. It is not a challenging question. It is an intelligent one. Here's what I want you to understand at the deepest level. Blood pressure management after 65 is not one size fits all. It never was. The guidelines that established universal targets were built on population data, averages across thousands of people. Your body is not an average. Your arterial stiffness, your kidney function, your neurological resilience, your fall risk, your cognitive baseline, these are yours specifically. And a blood pressure target that is ideal for someone else your age may not be ideal for you. The goal of blood pressure treatment is not a number. The goal is a life. A life with clear thinking. A life with steady balance on the stairs. A life where standing up doesn't require grabbing the wall. A life where the medication that's supposed to protect you isn't quietly making you older faster. Norma goes for walks now. Harold is back to running his community board meetings without losing his train of thought. Leonard is taking his morning walk. None of them needed perfect numbers. They needed the right numbers for who they actually are. And you deserve the same thing. Tell me in the comments, has your doctor ever discussed a specific blood pressure target for your age? Have you experienced dizziness when standing, morning brain fog, or fatigue that appeared after a medication change? What part of what I shared today surprised you most? Where are you watching from? If this raised questions you want to explore further, there's a video here about the medications that most commonly cause blood pressure to drop too low, and the signs most people miss until something goes wrong. It follows directly from today's conversation and fills in a part of the picture I think many of you will recognize. Work with your doctor. Ask the specific questions. Take your home readings. And remember, the goal was never the number. The goal was always you.